Hello everyone, welcome back to the channel, that is Obstetrics and Gynecology Simplified. Today we will discuss a very important topic, that is polycystic ovarian syndrome. Previously it was called as polycystic ovarian disease. So what was the difference? In polycystic ovarian disease, the difference is that it comprises only, means we know if there is only a definite signs and symptoms, there is a definite diagnostic criteria, and there is a definite treatment, there is a definite pathophysiology. Okay, so that was a disease. But now, due to its multifactorial involvement, due to involvement of the multiple factors, this is called as polycystic ovarian syndrome. That is, it is a syndrome. It constitutes many things. Okay, the factors are multiple. There is involvement of the environmental cause, genetic cause, various mutations of the chromosomal genes. Okay, so let's start. See, PCOS, that is polycystic ovarian syndrome, we will discuss about history, then pathophysiology, diagnostic criteria, then diagnosis of the PCOS, clinical management, then something about adolescent PCOS, and also PCOS in reproductive age, as well as PCOS in menopause. Okay, and see, there is a very important aspect to PCOS, that is the social aspects. You must have been seen various reels in Instagram. All the influencers, they are trying to just manipulate people to do certain things, to eat certain things, so that we can manage PCOS. Okay, see, these are the influencers, those who are just trying to manipulate. They are just giving the examples of the food, the lifestyle, okay, the environmental changes, but you cannot change the genes. Okay, so these are the symptomatic treatment. The what we do, what we eat, what we exercise, the lifestyle, these are the modifiable changes, and also these are temporary, these are symptomatic treatment. Okay, so this will not change the gene that carries the PCOS. Okay, so but that also does not mean that we will not do the environmental changes. Like, we have to see what are the social aspects. Due to acne, hirsutism, and also the poor body image due to increase in weight, obesity, that will lead to poor body image, decreased sense of feminism. Okay, and also she will feel less feminine because of increase in hair in chin, okay, and face, and in the upper chest. Okay, so she will feel less feminine, and the self confidence will also decrease, as well as there will be anxiety, depression, and also mood swings due to various hormonal changes. Okay, due to HPO axis changes, there will be mood swings, as well as the anxiety and depression, and also there will be infertility. PCOS leads to infertility. It leads to menstrual abnormalities or menstrual irregularities, and also that leads to infertility. So we will discuss slowly and in details about PCOS, so that you at the end of the lecture you will be able to understand about PCOS. Okay, so we will start about the history. So what was the history of PCOS? See, these are the two pictures showing. The first picture is Leventhal, and the second picture is Steen. So Irving Steen and Michael Leventhal. So previously what they did, Steen and Leventhal, Irving Steen and Michael Leventhal, they were practicing in a same college. Okay, so they were colleagues. What they did, they first took 7 obese patients. Okay, they took 7 patients who complained of acne, hirsutism, menstrual irregularity. Okay, they took 7 patients in their experiment. What they did, those patients, out of 7 patients, 4 of them were obese. So to all the 7 patients, what they did, who they complained of, the patients, they complained of menstrual irregularity as well as acne, and also PCO morphology and ultrasound. So what they did, they took a wedge biopsy of bilateral ovaries. Okay, they simply took wedge biopsy. What is wedge biopsy? The ovary, they took a cut. Okay, they took a biopsy. A part of ovary was cut out. Okay, and they sent to the histopathology. Okay, then what happened to the woman? those 7 women, what they did, they resumed. Okay, the menstrual irregularities became normal. Okay, and also they complained of acne and hirsutism, that also reduced, and the PCO morphology became normal. So what happened? Also later on, they had their babies. Okay, of course not due to the veg biopsy, but when they were sexually active, and then later on, as the ovulation was continued, and then that led to baby. Okay, so what they did in 1935, Irving Steen and Michael Leventhal, okay, both are from Chicago. Okay, both are from Chicago, and both worked in Michael Reese Hospital. So both were colleagues. Then they described 7 patients, out of which 4 were obese. I just told you that they described 7 patients who came with complaint of amenorrhea, that is menstrual irregularity, acne, hirsutism, and PCO morphology. And they did bilateral ovarian wedge resection. So what is this? See, this is the ovary. They took simply a wedge. So this much of ovary was removed. Then what they did? What they found out? They found out that all seven resumed menses, and 2 of them became pregnant later on in their reproductive life period. So what they speculated? They speculated that the thickened ovarian capsule prevented the follicles from reaching and escaping from the surface of the ovary. So in simple words, what they did? They speculated that the ovary, see, this is the ovary and this is the thickened, the capsule was thickened from the wedge biopsy. From the biopsy they took, they found out that this ovarian capsule was thickened. So the follicles that were maturing and ovulation could not happen because these follicles were not allowed to escape from the thickened ovarian capsule. So there was no ovulation. As there was no ovulation, so no egg was formed. As there was no egg, so they could not have a normal reproductive life. And what they did, they sent for histopathology. Okay, that ovarian wedge resection, what they did, they send it to histopathology. So what they found in histopathology, they found that there was twice the cross sectional area of the normal ovaries. Twice the cross sectional area of normal ovaries, and same number of primordial follicles. Because the follicles are not developing, so there are same number of follicles, and all of them are primordial follicles, and double the number of, these are comparison from normal ovaries. Okay, what we see in a normal ovary and what we see in a PCOS ovary. Normal ovary versus PCOS ovary. Okay, and double the number of developing atretic follicles. Or apoptotic follicles or dead follicles. Okay, and 50% thicker and more collagenized tunica or ovarian capsule, and 5 times thicker subcortical stroma, and 4 times higher cell mass. Okay, So finally, in the histopathologic study itself, they found out that the cross-sectional area was twice, there was thickened ovarian capsule or more collagenized capsule, as well as there was thickened stroma, and the number of primordial follicles was same, and the number of developing atretic follicles were more. So that led to no ovulation or anovulation. That led to infertility as well as menstrual abnormality. Okay. Then see, there are many causes of anovulation. So there are many causes of PCOS, and polycystic appearing ovaries result from the functional derangement of multiple factors and not a single cause. I've told you. And remember, the most common cause of anovulation is PCOS. Okay. Before it was called that the most common cause of anovulation was idiopathic, but now it is confirmed that the most common cause of anovulation is PCOS. Okay. See, this is the pathophysiology. What happens due to the derangement in the HPO axis? There is decreased release of, or there is no stability of the HPO or endocrine milieu. Then what happens? The GnRH that is secreted, that leads to no fluctuation in the level of LH and FSH. That is, the LH and FSH, these are stable. As we have discussed in the menstrual cycle, the LH gradually decreases, the FSH gradually, the LH gradually increases and causes LH surge. The estradiol level also gradually increases and then falls. The progesterone level also increases in the periovulatory phase, and then it in the luteal phase it is increased. So there is a difference in the, or there is a fluctuation in the hormonal levels that led to ovulation as well as normal menstrual cycle and normal fertility. But here what happens, there is constant level of LH, constant high level of LH and constant low level of FSH or normal level of FSH, but it is constant, there is no fluctuation. So the endocrine milieu is disturbed and it is stable. Okay, disturbed and stable is two different things. Stable means there is no variation or no fluctuation, but that is not normal. Okay, the normal is we have the fluctuation that causes menstrual cycle. So understood? Then see, due to that HPO abnormality, what happens? There is increased LH-FSH ratio, and that also leads to PCOS. Then what happens? There is insulin resistance due to hyperandrogenism, increased trauma, increased LH. Then there is increased androgen from the ovary, and then there is that led to hyperandrogenism and insulin resistance. Okay, so everything is interrelated. And what happened in obese PCOS? There is increased adipose tissue and there is increased insulin resistance, as well as the sensitivity is increased and there is hyperinsulinemia. Okay, so everything is interrelated. And also due to insulin resistance, there is hyperglycemia and increased synthesis of the fatty acid, increased SHBG production, and also there is increased total and free androgens. Okay, then coming to the pathophysiology of PCOS, I've told you it is multifactorial. It is a syndrome complex and not a single disease that we have a definite signs, symptoms, diagnostic criteria or definitive management. So it is a syndrome complex. So it contains or it is caused by multiple factors. So what are the factors? First, that is environmental factors, then genetic factors, and then lifestyle. Everything will be discussed here in details. So all these multiple factors, that what it causes? It causes that leads to excessive androgen production. This is the first pathophysiology and most important pathophysiology, that is excessive androgen production, that leads to defect folliculogenesis because androgen is folliculotoxic. Okay, that does not allow, increase in androgen level does not allow the follicles to develop, to mature and to release the oocyte. So there will be no ovulation. So androgen is folliculotoxic. You just imprint this in your mind that androgen is folliculotoxic. So increased level of androgen affects the folliculogenesis. Then what happens? Defect in insulin action. So defect in insulin action, what it does? It causes insulin resistance and hyperinsulinemia. Because of the resistance, there will be decreased sensitivity. So more and more amount of insulin will be released and there is hyperinsulinemia. Then what happens? What is the next pathophysiology? That is defect in gonadotropin secretion. I have told you now just that the endocrine milieu, which have normally it has fluctuations, but due to stability, due to no fluctuations, what happens? There is defect in gonadotropin secretion and constantly increased level of LH is maintained, and then that also causes excessive androgen production that leads to folliculogenesis, defect in folliculogenesis, and everything is interlinked. Okay. Then coming to the first pathophysiology. What is androgen production? See, this is the ovary. Okay. This is ovary and this is the cortex where all the follicles lie, and this is the stroma where all the vessels lie. Okay. So what happens? The theca cells in the ovary, it is the major source of androgen. Okay. The major source of androgen is theca cells. That is the ovary. Also, some amount of androgen is secreted by the adrenal. Okay. Adrenal gland, it is the minor source of, it is a minor source, and also adrenal and excess body fat. These are the minor source of androgen. So in PCOS, what is the normal level of androgen? See, in normal, it is less than 70 nanogram per dl. That is normal androgen level. In PCOS, there is more than 70 but less than 200 nanogram per deciliter. Okay. Also, hirsutism occurs at this level. And if more than 200 nanogram per dl, that it may be androgen secreting tumors or adrenal tumors, it may be. Okay. Then coming to the complications, what happens when there is excess androgen secretion? What happens due to excess androgen secretion? The complications is dyslipidemia, and there is increase dyslipidemia. That means increase LDL, bad cholesterol, and decrease HDL, good cholesterol, and increased level of triglyceride. Okay, this is the complication first. And then metabolic syndrome. So metabolic syndrome, and see what excessive androgens does. Excessive androgen, first it leads to symptoms, complications I have told you, dyslipidemia and metabolic syndrome. Then it causes acne and hirsutism. What is hirsutism? Hirsutism is growth of terminal coarse hairs, okay, in the abnormal areas. Growth of hair in terminal, okay, growth of terminal hairs in abnormal pattern. Okay, then also hirsutism, it is included in diagnostic criteria. Later on, I will discuss about the diagnostic criteria. Here, you remember that hirsutism is included in the diagnostic criteria. This is the one symptom that is included in the diagnostic criteria. Okay. Then, see, I've told you the abnormal lab values. What will happen? There will be increased LH, normal or decreased FSH, increased LDL, decreased HDL, increased level of triglyceride. And what about the DHAs? There will be mild increased because of the adrenal origin, mild elevated. And what about testosterone? Will be 70 to 200. Okay, understood? And also, what about the SHBG? SHBG will decrease, okay, due to decrease in production, hepatic production, that will decrease, and SHBG will decrease, that is, and there will be the free testosterone level will increase. Okay. Then coming to the next, that is what I've told you. See, this one is the pathophysiology. This is a picture from Sperov. Okay. See, what happens in normal menstruation? There is, see, the LH is increasing, that is LH surge, estradiol level is increasing, and there is, see, the progesterone level is also increasing and decreasing, then FSH level is also fluctuating. But what happens in PCOS? That is steady state, okay, or stable state. There is a steady state, the FSH is constantly low, estradiol is constantly low, progesterone is constantly low, and increase in LH, but that is also constant. There is no surge. There is constant high level of the estrogen. See, the follicles here are arranged in a necklace pattern, and there is no dominant follicle. No single dominant follicle is present. Every follicle is of similar size and similar shape, and there is no dominant follicle, so mature follicle. But here in the normal ovary, there is mature follicle as well as there is ovulation, and there is formation of the corpus luteum. Okay, everything is there, but here in PCOS it is not there. So this is a picture of endocrine milieu of normovulatory and PCOS. I mean, this is PCOS and this is normal. So normally there is menstrual cycle due to fluctuation of the hormones, but here there is a steady state. There is constant increase in the LH level that leads to an ovulation. Okay. Then coming to the defect in gonadotropin secretion and action. I've told you here, we will just write it down, everything I've told you now. By now, we will write it down now. See, this one is complete excessive androgen production, then coming to the defect in gonadotropin secretion. Okay. Gonadotropin secretion. Just write it down with me. What happens due to abnormal LH secretory dynamics? What happens? There is increased LH bioactivity and increase androgen. Okay, by the ovaries due to expanded ovarian stroma. Okay, and also there is contribution of hyperinsulinemia. Everything is interrelated. I'm just writing it here just to remind you that there is insulin resistance, hyperinsulinemia, and that also leads to androgen production. Okay, so adrenal production is also increased in women with PCOS. It is observed that adrenal androgen production is also slightly elevated with women with PCOS. Okay, how did they know? How did they know that adrenal androgen production is elevated in PCOS? First, they did a test, and also what they did when they gave GnRH agonist and ovarian androgen production was suppressed. Ovarian androgen production was suppressed by giving GnRH agonist. Okay, and still also, even after suppression of the ovarian androgen secretion, there was increase in level of androgen. So they found out that means adrenal androgen is also mildly elevated in case of PCOS. Okay. Okay. But 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 adrenal androgen has no intrinsic androgenic activity. But also that contributed to but also it contributed to the pathophysiology of PCOS. So directly or indirectly it is linked, but somehow it did not have any intrinsic androgenic activity. Just remember that. But still also that contributed to the pathophysiology of PCOS. Okay, understood? How? By peripheral conversion to testosterone. Okay, understood? Then anovulation in PCOS is due to folliculotoxicity of the androgens and absence of LH surge. So write it down. Anovulation is due to first is due to folliculotoxicity of androgens and also absence of LH surge. Absence of LH surge. Okay. Then coming to insulin resistance. See, insulin resistance is due to also hyperandrogenism. Okay. It's due to hyperandrogenism. Okay. And it is more common in obese, but also It is more common in obese. What is the prevalence? The prevalence is 50 to 70%. Okay, in obese there is 50 to 70% prevalence of insulin resistance, but also few percentage up to 35%. Okay, also there was insulin resistance in lean PCOS. Okay, so first association between insulin resistance and hyperandrogenism was recognized by which two people? Archard and Thyers. See, first association between insulin resistance and hyperandrogenism was established by Archard and Thyers in 1921. Okay, and see here up to 35% of the women with PCOS exhibited what? Impaired glucose tolerance. See, out of this 50 to 70%, see 50 to 70%, I'm not just able to find a correct pen to write here. 50 to 70%, out of this 35% exhibited glucose tolerance, impaired glucose tolerance. The importance, I will just mention it down later, that why the impaired glucose tolerance is important and what test is used to find out the insulin resistance. In that case, I will just discuss it just 5 minutes later. Okay, impaired glucose tolerance. Okay, 35% out of 50 to 70%. Okay, then see in obese PCOS, 70 to 80% are insulin resistant, and in lean PCOS about 20 to 25% are insulin resistant. So this is the fact from Sperov. Okay, then what they does, the insulin resistance that also leads to increase hyperandrogenism, and there is increased insulin resistance, and also that leads to dyslipidemia. Okay, so that contributes to, so finally insulin resistance, it contributes to dyslipidemia. Okay, then what about how we know that hyperandrogenism occurs? See, hyperandrogenism occurs by two ways. First, due to thicker cell hyperplasia, okay, by stimulating the synthesis of the androgen from the ovary. So here, when the thicker cell is hyperplasia occurs, there is increased androgen production from ovary, and also due to decrease SHBG, sex hormone binding globulin. Okay, sex hormone binding globulin. that is decreased. See, what does SHBG does? It binds the testosterone level. Okay, so what happens? The level of free testosterone is decreased. So when the level of free testosterone is decreased, in normal female, the level of free testosterone is only 1%. In males, it is only 3%. Okay, so there is mild difference. So due to that 3%, the testosterone acts that is present in the males, and only 1% that is free testosterone, that is 1% that is present in the females. Others, majority of the testosterone that is bound, that is present in bound form both in males and females. Okay, that is the role of sex hormone binding globulin. So when the sex hormone binding globulin decrease, there is increase in the level of serum testosterone. Okay, so that leads to hirsutism, or the features of hyperandrogenism occurs when there is increased level of testosterone. Okay, so how can insulin resistance be detected? By insulin resistance can be detected by serum fasting level, serum fasting blood sugar level, by serum fasting insulin, which should be less than 4.5. Okay, then insulin resistance, it also leads to acanthosis nigricans, that also leads to acanthosis nigricans, and a syndrome that is associated is Hayran syndrome. What is Hayran syndrome? See, HA is hyperandrogenism, then IR is insulin resistance, and AN is acanthosis nigricans. Acanthosis nigricans is the velvety patches that is present around neck, around the axilla, around the inframammary portion. Okay, these are the velvety hyperkeratinized thickened epithelium, or epidermis is thickened, and it is velvety and dark in color. That is the sign of insulin resistance. Okay, so this is the syndrome that is associated with PCOS, that is Hayran syndrome, that is HA, that is hyperandrogenism, insulin resistance, and acanthosis nigricans. Okay, that is present around neck. Okay, then SCOG recommends that to do 2-hour baseline, 2-hour OGTT to detect insulin resistance or impaired glucose tolerance. Okay, what is the result? What we will find, that 30 to 35% of PCOS patients have impaired glucose tolerance, and 10% already have diabetes. Okay, so baseline 2-hour OGTT, I have told you that most of the people have, say, 30 to 35% people exhibited the impaired glucose tolerance. So SCOG recommended 2-hour OGTT value. So, and they found out that around 30 to 35% of the PCOS patients, they had impaired glucose tolerance. Okay, then coming to the next, that is, what is the genetic consideration? What are the gene mutations? What are the chromosomes that are involved? See. This is focused on genes relating to the insulin receptor. Usually the chromosomes or the genes that carried the insulin receptors, that was found to be mutated, okay, or deleted. Then that led to insulin resistance, and then gradually the hyperandrogenism, and then there occur multiple symptoms of PCOS that focused on genes that were related to insulin receptors. Okay, understood. So what are the chromosomes? See, P450, CYP11, P450, CYP17, and SHBG and FSH receptors were involved. Then other possible genes, DA, NND1A, that is differentially expressed in normal and neoplastic containing neoplastic domain. Okay, neoplastic domain, D4 domain containing protein A. This gene is involved, and also THADA, thyroid adenoma associated protein. Thyroid adenoma associated protein, and also other genes like present in chromosome 9, 2, 11, 8, and many more. So what are the receptor? See, this one is LH, CGR, then FSH receptor, THADA, then DNND1A, and YAP1, that is present in chromosome 11. Okay, THADA and DND1A, these are present in chromosome 2. FSH are also in chromosome 2, and LH in chromosome 9. Okay, and YAP and GATA4 in chromosome 8. Okay, so basically you just remember, you have to just remember P450, that is CYP11, that is mutated, and CYP17 as well as SHBG and FSH receptors also affected. Other genes like DENND1A, THADA, and the chromosomes. You have to remember the chromosomes, that is 2, 8, 9, and 11. Okay, then what are the menstrual abnormality that occurs? There occurs oligomenorrhea, amenorrhea. Why? Due to anovulation. Okay, so due to anovulation, or as there is no LH surge and there is no ovulation, so there occurs oligomenorrhea or amenorrhea. So what are the key points? Just to write it down. Key points. First, PCOS is not a specific endocrine disease, but a syndrome. The Diagnosis of PCOS is clinical. Okay, based on clinical history and examination, physical examination. And although present in most women, although see polycystic ovary are present in most women, they are not diagnostic. That means the only the ultrasound criteria, it is not diagnostic. But not diagnostic. But one of the diagnostic criteria. Okay, that I will be telling you in details on diagnostic criteria and the management, investigations and management. And insulin resistance and compensatory hyperinsulinemia are common and play a important role. Play important role in PCOS. Okay, I've told you in details, and I've told you that 35% of women exhibit glucose tolerance, impaired glucose tolerance, and 10% exhibit impaired glucose tolerance, and 10% already have diabetes. Okay, and gonadotropins levels or ratios are not reliable. Okay,